efficacy might be the easiest of these three terms to compare. Efficacy is the effectiveness of a drug, and that's shown by the maximum height. In order to compare efficacy for a couple of drugs, look for the curve that is the tallest. The tallest curve would be the drug with the greatest efficacy. So these are our dose-response curves, where we're going to compare affinity, potency, and efficacy. Let's take the curve on the left and compare drug A to drug B. The first term I want you to compare is affinity. In order to compare affinity, you have to look at the slopes for drug A and drug B. Notice how the slopes are parallel. Since the slopes for A and B are parallel, what that means is those two drugs work on the same receptor. If and only if the drugs work on the same receptor can you compare affinity. So the slopes have to be parallel. What do you say? You say since A is shifted closer to the y-axis, drug A has greater affinity for its receptor compared to drug B. When you think about potency, it doesn't matter if the slopes are parallel. You just simply look for the curve shifted most to the left. Curve A is closer to the y-axis. That indicates that drug A also has a greater potency than drug B. So to summarize those things, greater affinity and greater potency for drug A compared to drug B. Notice though that the curves reach the same height. Drug A and drug B both reach 100% response. That means they have equal efficacy. They are the same when it comes to their effectiveness. Now let's look at curves for X and Y. Notice how, if we start with affinity, notice how the slopes are not parallel for drug X and drug Y. Since the slopes are not parallel, you should conclude that drug X and drug Y work on different receptors. Since they work on different receptors, you cannot compare their affinities. Affinity is a term that you can only use when you're talking about a single receptor with multiple drugs. When I look at drug X and compare its potency to drug Y, the curve for X is shifted closer to the y-axis, so drug X has greater potency compared to drug Y. Notice also that drug X, the curve reaches a greater height. Drug X goes all the way to 100% response. Drug Y falls well short of 100%. So you would say that not only does drug X have greater potency, it also has greater efficacy. Now we're going to explore the concept of full and partial agonists. We use the term full agonist to describe an agonist that reaches its maximum response. If you're plotting it on a percent scale like you see in this graph, if the agonist curve reaches 100%, as we see with drug B would be a full agonist. If I told you that curve A and curve C also represent agonists, you would have to describe those as partial agonist. Partial meaning their maximum response is less than 100%. And we see that for both curve A and curve C. We're really just comparing efficacies here. So curve B has a greater efficacy compared to drug A and drug C. In case you're thinking that a partial agonist is really an ineffective drug or a drug that would be kind of useless, that's not really true. Because if you look at your dose-response curve here, if you look at the responses on the lower part of this scale, let's say it's 50% or less, and that is the desired response that you want from your drug, all three of these drugs would give you that effect. Drug A, drug B, and drug C would all reach at least the 50% mark. But if I wanted a response from this particular drug or in my patient that's in the upper range of the dose-response curve, up around 80, 90, or 100%, only drug B would give me that effect. This graph shows what's called the duality of partial agonists. You see, in the body, partial agonists can actually have different types of actions. By definition, a partial agonist can stimulate the receptor. It can act as an agonist, after all. This graph is here to show us what happens when a partial agonist is placed in the presence of a full agonist. Obviously, you can start to predict that the partial agonist and the full agonist can compete for the same receptors. Let's take a couple of examples and then we'll go through the graph. The first is the example of the drug Pendolol. You probably recognize pendolol by the last four letters of its name. OLOL indicates that it's a beta blocker, and that is correct. Pendolol is a beta blocker, but it has the special property of being a partial agonist. That means if you could somehow isolate a heart and add pendolol to that heart, pendolol can actually directly stimulate the beta-1 receptors on the heart. It acts as a partial agonist. But of course, an isolated heart preparation is not a whole body experiment. That's not a real situation clinically. What happens in the body when you put pendolol in somebody's body who already has epinephrine or norepinephrine stimulating that heart? Well, epi and norepi are full agonists. So what happens when you have a full agonist and a partial agonist in the same situation? They compete for those receptors. In fact, the action of pendolol is going to be to reduce the effect of the full agonist. Think about it this way. Every time pendolol binds to a beta-1 receptor, epi and norepi can't bind to those same receptors. So the overall effect of your full agonist is going to be reduced. There's really kind of a similar story if you think about the drug tamoxifen. You've learned about tamoxifen perhaps as a SERM, as a selective estrogen receptor modulator, which is kind of a fancy way of saying that tamoxifen acts as a partial agonist. If you were to have a postmenopausal woman, no estrogen in her body, and you gave that woman tamoxifen, it would act as an agonist. It acts as a partial agonist. It would stimulate those estrogen receptors. What if you give tamoxifen to a woman who has estrogen receptor positive breast cancer? If estrogen is stimulating the growth of the breast cancer and you give that woman tamoxifen, that drug is going to compete for the binding to those estrogen receptors with the estrogen that was stimulating it. Ultimately, tamoxifen in the body, in the presence of estrogen, works as an antagonist. That's probably the most important take-home message. Partial agonists in the body actually work as antagonists. They inhibit the binding of the full agonist. When I look at the graph, typical dose-response curve, notice the partial agonist alone reaches some maximum response that's less than 100%. But the other part of this graph shows what happens if I start with a dose of a full agonist, which is going to be up around 100%, and then I start adding partial agonist into the system. The effect of that full agonist is going to be reduced. In fact, the more partial agonist I add, the greater the reduction in the response I'm going to see. If I keep adding more and more partial agonists, though, the response doesn't go to zero. The response, in fact, only reduces to what the maximum effect of a partial agonist all by itself would be. This is different from if this was truly a competitive antagonist. If this was a pure antagonist, I could block enough receptors to take the response of the full agonist all the way down to nothing. That doesn't happen with a partial agonist. It goes from about, in this case, 100% down to about 50%, which represents what the partial agonist all by itself would do. Kind of a final thought is, in that situation, adding the partial agonist in the presence of a full agonist, if I add enough partial agonist, that's all I'm going to see. I won't see the effect of the full agonist anymore. This graph allows us to talk about the concept of competitive and non-competitive antagonism, and also to look at the concept of potentiation. If you look right in the middle of this graph, you see what's labeled as control. Well, the control in this case is actually the agonist drug. And on the x-axis, where it says log dose of the drug, we're actually plotting the log dose of the agonist. So when I look to the right and I see a competitive antagonist, keep in mind that most antagonists are in fact competitive. If we talk about drugs in our review and we say, well, that drug is an antagonist, your assumption is going to be that it's competitive, because that's the more common action of a drug. Rarely we're going to see some drugs that are actually non-competitive. If I look at the curve, I notice how the competitive antagonist curve is shifted to the right compared to the control. What this is showing us really is it looks like the potency of the agonist has been decreased, because the curve has been shifted to the right. When I give a fixed dose of a competitive antagonist, because of the competitive nature of that drug, I can increase the dose of an agonist and essentially outcompete the competitive antagonist. Did you catch what I just said? If you add more agonist, you can overcome the competitive antagonist. So why does the curve shift to the right? Because I'm using more agonist drug. And that means an increase in the amount, an increase in the dose. That is a shift to the right. Then look at the non-competitive antagonist. Examples of non-competitive antagonists, drugs like phenoxybenzamine or aspirin, allopurinol, and proton pump inhibitors, and probably others that you can think of. The non-competitive antagonist, notice down at the bottom of my slide, reminds us that many times a non-competitive antagonist is actually binding irreversibly to the receptor. Competitive antagonists, on the other hand, those are reversible binding. They're going to reversibly inhibit the receptor. And it's all about the type of bonding that takes place. A competitive antagonist binds to the receptor through weaker ionic bonds. Non-competitive drugs most often are going to bind by very strong covalent bonds, making them irreversible. Think about it that way, that if I've bound up the receptor with a non-competitive antagonist, I can no longer bind that receptor with an agonist. I have fewer receptors available to bind the agonist. So when I look at the shape of the graph, what a non-competitive drug does is it's going to decrease the maximum response of my agonist. Another way to say that, it decreases efficacy. So when you compare one more time, the competitive antagonist shifts the curve to the right, decreased potency. The non-competitive drug shifts the curve downward, decreasing efficacy. The shape really gives it away. We also have an example of potentiation. Potentiation is rare. There are not a lot of examples, and probably the best example is when you add a benzodiazepine in the presence of GABA. Well, if that's my example of potentiation, what's the control in that case? What's the agonist all by itself? Well, of course, that would be GABA. So imagine GABA is your control, and the example of potentiation is GABA plus a benzodiazepine. In this case, the curve shifts to the left. If you look at the word potentiation, it almost has the word potency built into it. In fact, I'm going to increase potency when I shift to the left. In other words, it doesn't take as much GABA to get the same effect in the presence of a benzodiazepine. That's probably as detailed as we need to get, but some of you already know about mechanisms of these drugs. If you know that benzos, for example, are going to increase the frequency of chloride channel opening, that only happens in the presence of GABA. So benzos are going to help GABA open that channel more often. If we want to summarize the different types of antagonism, we just covered one type, which is called pharmacologic antagonism. Pharmacologic antagonism divides into the two components that we just covered on the previous slide, competitive and non-competitive antagonists. It really implies that you've got an agonist and an antagonist, and they both target the same receptor. I've diagrammed that for you on my slide. So you have an agonist that can stimulate the receptor and an antagonist that can block that receptor, either competitively or non-competitively. The key, two drugs, both of which target one receptor. A second type of antagonism is physiologic antagonism. In this case, you're dealing many times with two different agonists that oppose each other. The text tells you about a vasoconstrictor combined with a vasodilator. How about a real example? Phenylephrine is a potent vasoconstrictor. It works through alpha-1 receptors, whereas nitroglycerin is an important vasodilator working through nitric oxide. Those two actions, even though they're mediated by different receptors and different pathways, those two actions oppose each other. So let's draw a diagram. So agonist 1 stimulates its own receptor. Agonist 2 stimulates its own receptor, and those two receptors oppose each other. And that's what we call physiologic antagonism. You can probably think about maybe the best example, which is the autonomic nervous system. Isn't it true that the sympathetic nervous system opposes the parasympathetic nervous system? Each of those systems uses its own neurotransmitter and different receptors to cause that effect, and they oppose each other. For example, on the heart, muscarinic M2 receptors stimulated by acetylcholine are going to slow the heart down, whereas beta-1 receptors stimulated by norepinephrine are going to increase the heart rate. Opposite effects, that's what we call physiologic antagonism. Our third example is called chemical antagonism. Chemical antagonism is where you have two drugs that actually bind to each other. There is no receptors involved in this interaction. So what you're seeing is a drug-to-drug complex, like you see with protamine binding to heparin. Two drugs acting to bind directly to each other independent of receptors. This is what our chelators do as well. Metal chelators bind up the metal independent of acting through a receptor. Let's summarize the three types of antagonism. The way that you can figure out pretty quickly what type of antagonism you're dealing with, you're always going to have two drugs. It's the number of receptors that's going to vary. So if I have two drugs and they bind to each other with no receptors involved, that's chemical antagonism. If I have two drugs, one stimulates the receptor and the other blocks that same receptor. Two drugs and one receptor, that's pharmacologic antagonism. But if I have two drugs and two different receptors, and the two receptors oppose each other, that's physiologic antagonism. Next we have what's called quantal, also called cumulative dose-response curves. I actually happen to not like either of those terms. I tend to refer to these graphs as population curves, and that's the key. These are graphs that are going to look at the percentage of the population that responds to your drug. It's this type of curve where you can estimate an ED50, the effective dose, in 50% of the population, and also a toxic dose to 50% of the population. So when I look at the graph, once again I'm plotting dose, but this time versus the percent of patients responding. In this type of population graph, I can look at a therapeutic curve or a toxic curve, and it's from looking at those graphs I can calculate a therapeutic index, which is formed by the toxic dose in 50% of the patients divided by the effective dose in 50% of the patients. Notice the alternate equation is LD50. LD stands for lethal dose 50. Those are obviously not experiments that we do very commonly. Have a hard time getting people to volunteer for those types of experiments. But TD50 over ED50, that's what you should concentrate on. So can you calculate the therapeutic index given this graph right here? Sure you can. If you look at the therapeutic curve, if you go to the 50% mark, go over to the curve for therapeutic and come down to the x-axis, you see it corresponds to 2 milligrams per kilogram. You do the same thing for the toxic curve, go up to 50%, go over and come down, you see that it corresponds to 10 milligrams per kilogram. So what's your therapeutic index? 10 divided by 2, which equals 5. The therapeutic index for this drug is 5. If you think about what that really means, it really means that if you take 5 times the recommended amount of the drug, on average you're going to get toxicity. You tell your patient to take one of these pills once a day and they say, nah, I'm going to take 5. Chances are good, given that this is the example we're talking about, that they're going to get toxicity. Again, some people do that, right? Don't people take more drug than we recommend? I call it the just-in-case rule. Not sure if you're familiar with this. I didn't know this, but for years I discovered that my father actually practiced the just-in-case rule. He once told me, I was taking some ibuprofen, and he once asked me why I was taking 2 ibuprofen. I said, because I have a headache. And he says, why just take 2? He says, take 4, just in case. And that actually explained a lot about what was going on and some of the troubles we were having with his medication. But if that's what your patient thinks, that more is better, what if it's this example? They say, well, I'm going to take 5 times what the doctor recommends. Well, you're going to get toxicity. So clearly, in order to be a safer drug, you want it to have a higher therapeutic index. The larger the number, the safer the drug is. That means the farther away your toxic dose is from your effective dose. If you look at a graph, that means the safer drugs are the ones where the curves are spread farther apart, and the more dangerous drugs are where the curves get close together. So what if I take toxic dose 50 divided by effective dose 50 and I get a number like 2 or less? Those are my really low therapeutic index drugs. Those are some of our most dangerous drugs. And here's a list of some of those that actually become very popular step 1 questions. Theophylline, digoxin, warfarin, lithium. All are drugs with a low therapeutic index. That means in a drug interaction question, if I have a P450 inhibitor in theophylline, remember the example from earlier? Theophyline's plasma levels are going to be higher. And that would be the case for a lot of drugs, but why is it that theophylline shows up in the test question or digoxin or warfarin show up in those test questions? That's because those are more dangerous drugs, and raising their plasma levels even slightly can lead to significant side effects, significant and possibly fatal side effects, making them better candidates for test questions. This table looks at drug development and testing. Really gives us an opportunity to talk about clinical trials. It's possible that you can get a question on your exam related to clinical trials. Mostly you need to pay attention to the design of the trial and the purpose of the trial. Before we put a drug into clinical trials, we do preclinical trials on animal models, and sometimes those studies can last for a number of years. But focus most of your time on the 4 phases of clinical trials. When I think about phase 1 testing, first of all, phase 1 is done in healthy volunteers. People volunteer. Occasionally we will pay these folks, but they will volunteer to be a part of phase 1 trials. Notice since it's healthy volunteers, there's no way that you're testing for efficacy at this point. The only thing that you can test in these healthy volunteers is safety in dosage. To say it another way, the purpose of phase 1 is to find a safe dosage to move on into phase 2. But we're doing that in healthy patients. We're doing that in healthy people. Phase 2 trials typically are the first time that we're going to test the drug out in patients. The numbers go up. Now we're talking about hundreds of folks involved in a phase 2 trial. Since we're dealing with patients, we can evaluate effectiveness. Phase 2 typically is the first time we test for efficacy. How about this question? What phase of clinical trials do most drugs fail? The answer is phase 2. Most drugs that enter clinical trials will fail in phase 2. In fact, if they make it through phase 2, we're going to do an even more extensive study on those drugs, but if they fail in phase 2, typically that is the end of that drug. We get through phase 2, we found that the drug was effective. Now we do a more extensive phase 3 trial, typically with thousands of patients. The purpose of phase 3 is to confirm the effectiveness in a larger patient population and also to look for common side effects. Keep in mind, it has to be common side effects because you're only talking about a couple of thousand patients. You're never going to see the rare side effects occur with such a small patient population. When the drug makes it through a phase 3 trial, it undergoes a review by the FDA. If it's approved by the FDA, it then goes into phase 4 trials, what's called a post-marketing surveillance. This happens after the drug has been approved to go out on the market, and now patients are taking this drug and physicians are prescribing it. In fact, this is an opportunity for the average physician to possibly get involved in clinical trials. They can volunteer to be a part of collecting data in phase 4. Importantly, the purpose of phase 4 trials can determine the common side effects, really confirming some of those that we might have seen in phase 3, but also to discover rare side effects. This is that time when side effects that occur in, let's say, 1 in 10,000 or 1 in 100,000 patients are discovered, because this is the only time that we're getting a large enough sample size to detect those rare side effects. It's why some people advocate that you should wait at least 3 to 5 years after a drug goes out onto the market before you begin prescribing it to your patients. That's going to be a hard rule to follow, by the way. A lot of pressure on you by your patients to prescribe these new medications. But why would you wait 3 to 5 years to start prescribing a drug? Clearly, it's because we don't have enough data about rare side effects. And some of you might remember the lesson learned from years back with the COX-2 inhibitors. For as popular as they were when they first hit the market, while we were doing our phase 4 trials, we discovered some rare side effects that those drugs may cause, rare side effects like death. We have a table on teratogenicity. It's basically how the FDA classifies drugs and their pregnancy categories and their pregnancy risks. We have 5 different categories that we're going to use: A, B, C, D, and X. Of course, this is all based on data that we've collected either in animals or in humans, and hopefully both. When you think about a drug and we call it category A, those drugs are considered very safe in pregnancy. That's the good news. The bad news is that almost nothing is in category A. You know what's in category A? Folic acid. That's right. You're pregnant, folic acid. We're willing to give you folic acid. Pretty much folic acid and water is about what we're willing to give you in pregnancy. Folic acid, very safe in pregnancy. We have drugs that are categorized as B, which are considered safe in pregnancy. But of course, this is where it starts to get scary. Look at C. Category C drugs may be safe. If you look at the table, notice how it shows you that there are no studies available in humans. And that's kind of scary. Well, why does a drug get put into category C? I call it the unknown category. If we don't know anything about a drug's teratogenic risk, we tend to put it into category C. If we learn over time that the drug is safe in pregnancy, we might move it up, let's say, to category B. But if we discover that the drug is harmful to the fetus, then we drop it down into D or X. And if you're thinking, how can we have a category where it's unknown, where we don't have the data? Well, how often do you think pregnant women are volunteering for clinical trials? Very, very difficult to collect this data, so it's a slow process over time. Once you get down to category D or category X, those are teratogenic drugs. Those are drugs, we have human studies that show those drugs have caused harm to the fetus. But there is a difference in how category D and category X are viewed in terms of your patient. For example, a category D drug, you might decide to actually continue your pregnant patient on that category D drug only if the benefits of that drug to the patient outweigh the risks to the fetus. An example would be if you don't have any suitable alternatives to treat their condition. But with category X, you immediately discontinue the medication. Don't even think about continuing a patient on a category X type drug. Immediately discontinue. Again, both are harmful to the fetus, and we're going to talk about some examples in the rest of our lectures of drugs that are teratogenic, and if we know the specific teratogenic effects, those all make for very good test questions. Now that we finished Chapter 2, let's do a few practice questions together. Here's the first one. This is an opportunity for you to pause the video, review the question, think about it, come up with a correct answer, and then we'll discuss. So here we've got 4 drugs. They produce the same therapeutic effect by the same mechanism, but each has a unique toxicity. We're trying to figure out which drug is likely to have the highest incidence of toxicity. When I look at the data that's presented, I'm looking for information that helps me to determine toxicity risk for the drug. Median effective dose really doesn't tell me that, but TD50 over ED50 actually does, because that's my therapeutic index. And the rule on therapeutic index is the lower the number, the more dangerous the drug. By that rule, that would be choice B. 2.1 is the lowest number. That would be the most dangerous drug. That would be the one with the highest incidence of toxicity. But some of you still focused on the other column, median effective dose. And you saw numbers like 0.5 and 1 and 5 and 33. Really what those numbers are probably reflecting is more the potency of the drug. Drug A is more potent than B, and B is more potent than C, which is more potent than D, because it takes smaller amounts of those drugs to produce their effectiveness. So as a result, the first column is really not helpful in answering this question. Don't let it influence your choice of which drug has the highest incidence of toxicity. Here's our second question. Once again, pause the video. We will discuss. So, serious, possibly fatal adverse effects of a new drug may first appear only after the drug is approved for marketing by the Food and Drug Administration. The failure to detect these effects is best explained by the use of which of the following in the pre-marketing clinical trials. Remember, the fact that we don't see those side effects ultimately until the drug has gone out on the market is because the clinical trials in phase 1 and phase 2 and phase 3 have used a very, very small number of patients. The only way that you're going to detect rare side effects is when you have a much larger patient population, and that only happens in phase 4, the post-marketing surveillance studies that we do. So the correct answer here is E. There were just too few subjects to detect those rare events. Here's our third question. Once again, pause the video, review the question, and we will discuss. Leukotrienes are implicated in asthma, and they act via leukotriene receptors to cause bronchoconstriction. Albuterol, acting through beta-2 receptors, can oppose the actions of leukotrienes by causing bronchodilation. We want to know what term best describes this effect. If you go back earlier and we talked about the different types of antagonism, leukotrienes have their own receptor. Albuterol has its own receptor. You have two receptors, and the two receptors do opposite things. A two-receptor system is what we call a physiologic antagonist. Choice C is the correct answer. Remember, if it was chemical, chemical means that leukotrienes and albuterol actually bind to each other, and we know that that's not true. If it was pharmacologic, that means that leukotrienes and albuterol would be working on the same receptor, and we know that that is also not true. The next thing we're going to review are various signaling mechanisms. It's a good opportunity to bridge the biochemistry that you've learned with the pharmacology. We think about the different types of receptors and those signaling pathways. So we start with intracellular receptors, including receptors for steroids. So steroids can diffuse across the cell membrane. They can bind to their intracellular receptor. That drug receptor complex goes to the nucleus and stimulates gene expression. So when you think about steroids binding to intracellular receptors, this is a gene expression pathway. What I would have you think about is, how rapid of a response do you get to steroids? If steroids involve changes in gene expression, those responses are going to be slower to occur. In fact, let's make sure that we highlight that part of this text. The response to steroids, slow in onset, but long in duration. You see, once you form new proteins with the steroids, they tend to have a long-lasting effect. We have membrane receptors that are directly coupled to ion channels. If the receptor is directly coupled to an ion channel, you have to imagine this is a very rapid responding system, certainly as compared to the steroids, which involve changes in gene expression. Here, when the drug binds to its receptor, you're going to see changes in ion channels. For example, a sodium channel is going to open up and sodium is going to rush into cells. This action occurs completely independent of second messengers. Some examples of ion channel coupled receptors: nicotinic receptors. When acetylcholine stimulates a nicotinic receptor, you're going to see the opening of a sodium and potassium channel, where sodium goes into the cell and potassium is going to exit the cell. Another example would be GABA A receptors. When you stimulate those GABA A receptors, they're directly coupled to chloride channels, and a number of drugs can modulate that activity. We have receptors that are linked via coupling proteins to intracellular receptors. What we're basically talking about here are G proteins. You've learned a lot about G proteins. The challenge for us right now is to make sure that you can take what you know about G proteins, couple those directly to certain receptors, and then couple that with the drugs that either stimulate or block those receptors. There are three main types of G proteins that we discuss. On this slide you see GS and GI. Remember that these types of G proteins are opposite of each other. They both work through adenylyl cyclase, but GS, of course, are stimulatory G proteins. They're going to activate adenylyl cyclase to increase cyclic AMP production. It's actually similar to the action of the toxin from Vibrio cholera. Cholera toxin is going to increase cyclic AMP levels. What you have to do when you relate G proteins to the pharmacology is you have to tie the G protein to its receptor. There are a lot of receptors that are going to use GS pathways, but betas are really the most important for us to focus on right now. So the rule is all betas are GS. That would be beta 1, beta 2, and beta 3 receptors all work through GS proteins. GI, on the other hand, inhibitory G proteins are going to inhibit adenylyl cyclase. They're going to decrease cyclic AMP. Once again, exactly the opposite of GS. When I see that decrease in cyclic AMP through GI-coupled pathways, I'm going to have inhibitory effects on cells. Importantly, receptors that you have to know that are GI-coupled: alpha-2, muscarinic M2, and dopamine D2. The third type of G protein is the GQ pathway. GQ is totally different from GS and GI because it doesn't involve adenylyl cyclase or cyclic AMP. GQ is the pathway that's going to activate phospholipase C. Phospholipase C is an enzyme that's going to cleave membrane phospholipids, releasing the second messengers IP3 and diacylglycerol. IP3, of course, releases calcium from the SR, whereas DAG activates protein kinase C. Receptors that you have to match up with GQ would include the muscarinic M1 and M3 receptors and alpha-1 receptors. Here's a cartoon that diagrams exactly how phospholipase C is going to work on this molecule. In fact, if you ask yourself, what have I drawn here? What is this cartoon actually representing? It's representing phosphatidylinositol. You see the glycerol backbone, you see the two fatty acids, you see the polar head group there with inositol attached to it. Well, phospholipase C is going to cleave between the phosphate and the glycerol backbone. That's going to release inositol phosphate, which becomes IP3. IP3 then goes and releases calcium from the SR. What's left is glycerol with two fatty acids, and we call that diacylglycerol. In fact, it's not a bad opportunity for you to review the different types of phospholipases here. In fact, if I ask you, what is the phospholipase that cleaves off the first fatty acid here at the top of the diagram? That would be phospholipase A1. What's the name of the phospholipase that cleaves off the second fatty acid? Well, that's phospholipase A2. In fact, what fatty acid is normally found off of that second carbon? Well, phospholipase A2 releases arachidonic acid. That's part of the arachidonic acid cascade. So many times you find arachidonic acid in that location. We see where phospholipase C works on the other side of the phosphate. Between the phosphate and inositol, that's actually where phospholipase D works. I don't know about you, but I've always had this question in my mind. If we have phospholipase A1, A2, C, and D, what's the question, folks? Where's the B? Well, of course, biochemists name the enzyme. Biochemists are going to reserve the B for biochemistry. So there's no B. There's just A1 and A2. Then there's C and D. This diagram shows us the different types of G proteins and also gives us an opportunity to look at their signaling pathways in a little bit more detail. So starting on the left, we see the molecule adenylyl cyclase. If I'm talking about a GS-coupled receptor, that receptor, when I activate adenylyl cyclase to produce cyclic AMP is going to then activate protein kinase A. It's important to remember the kinase in these pathways. And of course, the easy way to remember, it's A for the kinase, it's cyclic AMP, and A is also for adenylyl. GI, on the other hand, GI are inhibitory G proteins. They decrease the activity of adenylyl cyclase. Cyclic AMP levels go down. You inhibit the activation of protein kinase A. On the right, we see the GQ-coupled pathways, which involve phospholipase C. You see the cleaving of membrane lipids producing IP3, which releases calcium from the SR, and diacylglycerol, which activates protein kinase C. Protein kinase C goes with phospholipase C. When we think about the different types of receptors that are coupled to G proteins, rule number 1, all betas are GS. Rule number 2, if you take the 3 receptors that we've discussed, M2, alpha-2, and D2, you can remember the MAD2s. They're all inhibitory G protein coupled. Rule number 3 says most of my sub-1s and muscarinic M3s are GQ. Let's look at some examples of the sub-1s. Obviously, alpha-1, M1. The angiotensin II receptor is called AT1. It's always a little confusing. AT1 is an abbreviation for the angiotensin II type 1 receptor, and that, of course, is GQ coupled. The vasopressin V1 receptor, that's GQ, and the histamine H1 receptor, that's also GQ. So most sub-1s and M3s are GQ. Then there are a few that I call oddballs. There are receptors that don't fit into this pattern. Notice D1, histamine H2, and the vasopressin V2 receptor. Those are actually all GS coupled. So when you go back and summarize GS, it's all betas, but then it's D1, H2, and V2. Cyclic GMP and nitric oxide. Very important pathways because cyclic GMP is a second messenger in vascular smooth muscle. In fact, later on, when we're going through our cardiovascular drugs, we're going to look at exactly how cyclic GMP can relax smooth muscle. I've got a great diagram coming up later on in the lectures. But for now, what I'm going to do is I'm going to tell you the end of the story. I don't know if you've ever done that. Do you ever buy a book and sometimes you read the last chapter of the book just so you know how it ends to see if you really want to read the whole thing? I'm going to tell you the end of the story, and then later on I'm going to tell you the entire story about cyclic GMP and nitric oxide. So how does nitric oxide relax smooth muscle? It ends up causing dephosphorylation of myosin light chains. That's the final step, dephosphorylation of myosin light chains. We'll tell the rest of the story later on. You know, we have a couple of endogenous compounds, like bradykinin and histamine. Bradykinin and histamine are both vasodilators, and at least part of their vasodilating action is mediated through nitric oxide. We have receptors that function as enzymes or transporters. If you look at the long list of enzymes and transporters on this slide, you know, many of those are important. Many of those show up on your Step 1 exam. The way that we're going to deal with those is one at a time. As we go through the remainder of the lectures, we're going to go through each of those and talk about why that's important for your test. We have receptors that function as transmembrane enzymes. Importantly, this is how insulin signals and a couple of growth factors, epidermal growth factor and platelet-derived growth factor. These pathways for insulin and these two growth factors involve tyrosine kinase activity. That's important. Ultimately, the binding of the ligand causes a conformational change that causes these receptors to dimerize. The tyrosine kinase domains become activated, and then we're going to phosphorylate tissue-specific substrate proteins. In the margin is a clinical correlate about a couple of tyrosine kinase inhibitors. This pathway has become a very popular target for a number of drugs. We've got the drug imatinib, a very specific tyrosine kinase inhibitor, whereas sorafenib is a non-specific tyrosine kinase inhibitor. Both of these drugs will be discussed later on in our lectures. The final receptors that we're going to look at are receptors for cytokines. You should think about things like erythropoietin, somatotropin, interferons. This is what we call the JAK-STAT pathway. JAK stands for Janus Activated Kinase. In fact, this is what I call the insulin-like part of this pathway, because JAK is a type of tyrosine kinase. The difference between this pathway, however, and insulin is that the tyrosine kinase for the insulin receptor is intrinsic. It's built into the receptor itself, whereas JAK is a distinct molecule. JAK is a separate molecule from the receptor for the cytokine. JAKs are going to phosphorylate STATs. STATs are signal transducers and activators of transcription. STATs are very steroid-like because they mediate the gene expression part of this receptor. So if I were to put those two pieces together, how would you describe a cytokine receptor? It's like an insulin receptor has combined with a steroid receptor. I've got a tyrosine kinase activity with gene expression. JAK is a separate molecule, STAT is a separate molecule, and both are distinct from the receptor.